Welcome back to the deep dive. Today, we are undertaking, well, quite a massive project, really tackling the complexities of female reproductive health disorders.
hmm
And we're not just looking at these as, separate issues, but more as this interconnected system where things like common hormonal shifts can, down the line, turn into chronic problems, debilitating diseases, or even critical oncological concerns.
That's exactly right. And we've got quite a stack of clinical sources here, research, specialized clinical notes. Our mission today is really to distill all of this down for you into a highly structured, comprehensive breakdown. We want to go beyond just defining these conditions.
Right.
The goal is for you to walk away with a solid grasp of the etiology, what actually causes it, the pathophysiology, how the disease works, how it progresses and causes damage, and crucially, the key assessment data and the absolute priority nursing management for a whole range of these deviations. Think of it as a shortcut to really being well-informed in this vital clinical area.
Okay, let's unpack this then. We're diving right in, starting with infections, specifically pelvic inflammatory disease, or PID. This isn't just a simple infection, is it? It sounds more like a potential time bomb. If it's not treated, it seems to trigger this whole cascade of pretty devastating long-term consequences.
Yeah, PID, it's defined as a generalized inflammatory condition. And it can really affect the entire pelvic cavity.
The whole area.
The whole area. Depending on how far it goes, it could involve the ovaries, that's oophorytis, or the fallopian tubes, which is salpingitis, or it might even spread further into the vascular system, maybe the pelvic peritoneum.
Okay.
Now, when we look at the etiology, the cause, it's almost always polymicrobial.
Meaning multiple bugs.
Exactly. Multiple types of microorganisms are usually involved. Things like chlamydia, gonorrhea are common culprits that started off.
And these microorganisms, they often start lower down, right? Like in the vagina or cervix. And then they initiate this ascending infection.
Precisely. They climb up. From the lower reproductive tract, they ascend into the uterus.
Okay.
And from there, they can just keep going, right up into the fallopian tube.
And how does that happen? Is there a specific time?
Well, this ascent often happens when the natural protective barrier of the cervical mucus plug is somehow compromised. That can occur not just during sexual activity, which is common, but also sometimes following childbirth or an abortion, or even after certain gynecological surgeries.
Okay, so that's the how. Now, here's where the pathophysiology, how the disease actually works, seems really critical. Because the initial infection, the acute part, that's just the beginning, right?
That's just chapter one. Once that infection gets into the uterine tubes, the body mounts this huge inflammatory response trying to contain it.
Right, the immune system kicks in.
But the result of that intense inflammation is, unfortunately, significant cellular damage and the formation of scar tissue, lots of it.
And that scar tissue, that sounds like the real problem long term.
It absolutely is. That scar tissue is the villain here. It causes the uterine tubes to become blocked, rigid.
Yeah.
Sometimes tubo-ovarian abscesses can form.
Abscesses, too. Wow.
Yeah, pockets of infection on the ovaries or tubes. And these adhesions, this scarring, it basically distorts the normal anatomy of the pelvis. Plus, the infection can actually hijack the lymphatic system.
So it can spread?
It can spread through the vascular system, potentially becoming systemic.
And the big consequence of all that scarring, I mean, we have to talk about fertility.
Absolutely cannot overstate it. PID is recognized as a major cause of infertility, specifically tubal factor infertility.
Because the tubes are just too damaged.
The fallopian tubes, once they're scarred up like that, they simply can't do their job of transporting the egg properly. And the prognosis, how well someone does, it's directly tied to how many times they've had PID before and how quickly they got treatment.
So speed is critical.
Crucial. After even just one episode of PID, the risk of having an ectopic pregnancy, that's a pregnancy developing outside the uterus, usually in the tube it increases dramatically, maybe 6 to 10 times higher.
That's huge.
It is. And this whole devastating cycle, you get the infection, then the scarring, often chronic pain follows, and then infertility. It just highlights why early diagnosis is so vital and why we need to address the risk factors.
Right. What are the main risk factors we should be thinking about?
Well, having a history of sexually transmitted infections is a big one. Previous episodes of PID, obviously. Multiple sexual partners increases exposure risk. And in some cases, IUD use might be a factor, depending more on insertion risks and timing rather than the device itself long term.
Okay. So let's say a patient comes in, they're acutely ill. What are the assessment findings? What are the red flags that really scream PID?
Well, the clinical picture usually involves systemic symptoms first. So you'll see fever, a general feeling of being unwell, malaise,
Like the flu almost?
kinda,
Yeah.
yeah, plus nausea, sometimes vomiting.
Yeah.
Then you look for the specific pelvic signs. There's usually a purulent vaginal discharge, often foul-smelling,
Okay.
and pelvic symptoms like dysuria, that's painful urination, and dyspareunia, which is painful intercourse.
But the pain itself, is it distinctive?
It is. The
Yeah.
most definitive indicator is usually severe lower abdominal pain and tenderness. Often it's bilateral on both sides. And it gets much worse with any movement, like walking. So much so that the patient might walk really slowly, maybe hunched over.
Right.
And during a pelvic exam, the pain can be so intense. Clinicians sometimes call it the chandelier sign,
Why?
because the patient might literally jump up towards the ceiling from the pain when the cervix is moved.
Wow. Okay, that's a clear sign. So in terms of diagnostics, how do we confirm it? What tests back this up?
We definitely rely on lab findings that point to inflammation. So you're looking for significantly elevated leukocytes, that's the white blood cell count,
Mm-hmm.
an elevated erythrocyte sedimentation rate, or ESR, and an elevated C-reactive protein, CRP. Now, these are non-specific markers of inflammation.
Right. They don't pinpoint PID itself.
No, but taken together, in the context of the symptoms, they paint a pretty clear picture. We also take cultures, usually from the vagina and cervix, to try and identify the specific bugs causing the trouble.
To guide antibiotics.
Exactly. And an ultrasound is often really necessary.
Yeah.
It helps us look for any potential tubo-ovarian abscesses, which might need surgical drainage, not just antibiotics.
Okay. Let's shift straight to priority nursing management. If you have a patient admitted acutely ill with PID, what are the absolute priorities? What do we do first?
Well, beyond getting the medication started quickly, the priority goals are really facilitating drainage and ensuring comfort.
Drainage.
Yes. The key physical intervention is placing the patient in a semi-Fowler position.
So sitting up slightly.
Exactly. Head of the bed elevated. This uses gravity. It encourages any purulent drainage, any pus, to collect down in the lower pelvic area, rather than potentially spreading upwards into the upper abdomen.
Ah, so you're trying to contain it, prevent it from getting worse, like reaching the liver.
Precisely. Preventing upward spread, like causing liver capsule inflammation, Fitzhugh-Curtis syndrome, that's a crucial distinction.
Got it. What else for comfort and management?
Comfort measures usually include applying warmth to the abdomen like a heating pad. Sometimes warm douches might be prescribed, though less common now, the idea being to promote vasodilation and improve local circulation.
Okay.
Medication management is immediate. We start broad-spectrum antibiotics right away because it's usually polymicrobial.
Covering all the bases.
Yep. And then, of course, analgesics for the pain and antipyretics for the fever. And nursing education is absolutely vigorous here.
What do you need to stress?
The client must understand they need to complete the entire course of antibiotics, even if they feel better. And, critically, the necessity of treating all sexual partners.
Right. Otherwise, they just get reinfected.
Immediately. It
Yeah.
prevents that ping pong effect.
Okay. Really important points. We should also touch briefly on some other common inflammatory conditions. Let's start with vulvitis,
Right. Vulvitis, it's simpler in concept, just inflammation of the vulva.
the external area.
Exactly. And its etiology, the cause, is often contact-related. Because that area is constantly exposed, it's pretty prone to inflammation from either mechanical irritation or chemical irritation.
Like what kind of things?
Oh, things as simple as tight-fitting clothes rubbing or exposure to trapped urine or fecal material, maybe from incontinence. And very commonly, chemical irritants.
Chemicals?
Yeah, things found in perfume soaps, harsh douches, which we generally advise against anyway, and scented vaginal lubricants or pads.
And the main symptoms.
The cardinal symptoms are intense local itching pruritus and a burning sensation. It often gets worse during urination or defecation when urine or stool touches the inflamed skin.
Okay. And shifting now to candidiasis, the common yeast infection. The etiology here is fungal, right? Candida albicans.
Yes, that's the usual culprit. The pathophysiology is really about a disruption of the normal vaginal environment.
The ecosystem gets thrown off.
Exactly. The vagina normally has a healthy balance of bacteria, like lactobacillus, which keep it acidic and keep yeast in check. When these protective floors get wiped out most often by broad-spectrum antibiotic use.
Ah, antibiotics again.
Yeah, they kill the good bacteria along with the bad. This allows the Candida fungus, which is normally present in small amounts, to just flourish and overgrow.
Are there other risk factors?
Definitely. Candida loves a high sugar or carbohydrate environment. So poorly controlled diabetes mellitus is a major risk factor.
Okay.
Also, environments that trap moisture can contribute, like not drying properly after bathing, wearing synthetic fabrics that don't breathe well, or maybe prolonged use of certain types of tampons or pads.
And the clinical picture is pretty distinct for yeast, isn't it?
It usually is. You
Mm.
typically see a scant discharge, but it's thick, white, and clumpy,
Mm.
often described as looking like cottage cheese.
Right.
And that's accompanied by really intense vulval itching, burning, and often significant redness and swelling of the vulva and vaginal tissues.
So for management of both vulvitis and candidiasis, practical patient education seems key.
Absolutely paramount. For both, we focus on prevention and restoring balance. This means emphasizing proper hygiene, always wipe front to back, rinse the vulva gently with just water or mild, unscented soap, and pat dry completely.
Avoid rubbing.
Yes. And instruct clients to avoid all those potential chemical irritants we talked about, scented products, harsh soaps, douches. Wearing 100% cotton underwear is often recommended because it allows the area to breathe better.
And for treating the yeast infection specifically.
For treatment, antifungal medications are the standard. These can be over-the-counter creams or suppositories like meconazole, or sometimes a prescription single-dose oral pill like fluconazole, brand name Deflucan.
Okay.
And dietary advice can sometimes play a role too. Consuming yogurt with live active cultures daily might help some women, the idea being to reintroduce beneficial lactobacillus into their system.
Okay, let's transition now into more cyclic disorders. Starting with dysmenorrhea, which is basically painful menstruation. The structure of our sources here really emphasizes making an etiology distinction. We need to separate primary from secondary dysmenorrhea. Why is that so important?
This distinction is absolutely crucial because it tells us why the pain is happening and directs how we manage it.
Okay, so primary dysmenorrhea.
Primary dysmenorrhea has a chemical etiology. It's caused by an excess release of prostaglandins, specifically a type called PGF2 alpha, right from the cells of the shedding endometrial lining during menstruation.
Prostaglandins, we hear about those a lot with inflammation and pain.
We do. And in this case, these prostaglandins act locally on the uterus, causing the muscle fibers to contract really strongly. Hypercontractility.
And those excessive contractions, that's what causes the pain, huh?
Exactly. The super strong contractions essentially clamp down on the blood vessels supplying the uterine muscle. This leads to temporary uterine ischemia, a lack of oxygen-rich blood supply.
Ah, like a muscle cramp anywhere else, starved of oxygen?
Precisely. And that ischemia is what generates that classic sharp cramping pain.
Yep.
It's interesting, though. After childbirth, the uterine cavity often enlarges slightly.
Right.
This seems to allow for more efficient expulsion of those prostaglandins with the menstrual flow, which is why primary dysmenorrhea often becomes less severe for many women after they've had a baby.
Okay, that makes sense. Then we have secondary dysmenorrhea. You said this is a red flag.
It really is.
Hmm.
If a patient is experiencing severe, debilitating period pain, especially if it starts later in life, say after their 20s when they previously had milder periods, or if the pain just isn't responding to standard treatments like NSAIDs, we have to suspect an underlying cause.
So the pain isn't just from the prostaglandins themselves?
No. In secondary dysmenorrhea, the pain is linked to some other structural or pathological condition within the pelvis.
Like what?
We immediately start thinking about things like endometriosis, uterine fibroid tumors, maybe scarring from previous PID, or even, though much less commonly, ovarian cancer. Something else is causing the pain.
Got it. So the assessment data here is important too, because the pain often isn't just localized cramping, is it?
No, it can be quite systemic. Patients often describe sharp pain in the lower abdomen, but it frequently radiates to the lower back, down into the groin, even into the thighs.
Okay.
And it's often accompanied by other systemic symptoms like headache, nausea, sometimes bloating or diarrhea, all potentially mediated by those widespread prostaglandin effects.
So what's the therapeutic management, especially for the more common primary type?
For primary dysmenorrhea, the main focus is often on NSAIDs, non-steroidal anti-inflammatory drugs, like ibuprofen or naproxen,
Why those specifically?
because they are powerful prostaglandin inhibitors. They directly block the production of those chemicals, causing the cramps and ischemia.
Okay.
For them to work best, they should really be started just before the expected onset of the period or right as it begins and taken regularly for the first few days.
And if NSAIDs aren't enough, or for really severe cases,
Then oral contraceptives, birth control pills are often prescribed.
how do they help?
They work primarily by inhibiting ovulation. If you don't ovulate, the buildup of the endometrial lining each month is usually much less significant.
Ah, less lining means fewer prostaglandins released when it sheds.
Exactly. It significantly reduces the amount of prostaglandin available to cause those painful contractions. We also always emphasize non-pharmacological methods too.
Right.
Applying a heating pad to the lower abdomen can be really soothing. It helps relax the muscle spasms and improves blood flow. And dietary changes like reducing caffeine, alcohol, and maybe sodium intake around the time of the period might help some individuals.
Okay. Next up, endometriosis. This sounds like one of the most frustrating chronic pain conditions, partly because diagnosis can often be delayed. What's the fundamental pathophysiology here? What's driving this?
Endometriosis is defined by the growth of tissue that's similar to the uterine lining, the endometrium, but it's growing outside the uterus.
Where does it grow?
It can be found on the ovaries, the fallopian tubes, the ligaments supporting the uterus, the lining of the pelvic cavity, the peritoneum, sometimes even on the bowel or bladder.
And the key mechanism. Why does this cause problems?
The key is that this misplaced ectopic tissue still behaves like the normal endometrium. It responds to the monthly hormonal cycle. Estrogen makes it grow. Progesterone modifies it.
So it builds up.
It proliferates, thickens,
Hmm.
and then, crucially, when hormone levels drop before menstruation, it attempts to shed and bleed.
But it's trapped. There's no way out, like from the uterus.
Exactly. Unlike the uterine lining, which exits during menstruation, this blood and tissue gets trapped within the pelvic cavity. This causes significant inflammation and irritation.
And the body tries to heal that inflammation.
Correct. The body's response to this internal bleeding and chronic inflammation is to lay down scar tissue. This results in fibrous bands called adhesions. These adhesions are nasty. They can act like glue, fusing organs together that shouldn't be fused, like sticking the bowel to the back of the uterus or twisting a fallopian tube or encasing an ovary. This distortion and tethering leads to immense chronic discomfort and often severe pain.
So the clinical picture must be much more severe than just bad period cramps. What are the hallmark symptoms we should listen for?
Clients typically present with extremely painful menstrual cramps, yes. But critically, they often report significant abdominal or lower back pain between periods as well.
Pain outside of menstruation, that's a key difference.
A very key difference. Deep dyspareunia pain during sexual intercourse is also very common, depending on where the implants of endometriosis are located.
Okay.
They might also report heavy or prolonged menstrual bleeding, and sometimes even painful bowel movements or urinary symptoms if implants are irritating the bowel or bladder. And for many women, infertility is a major presenting issue, often due to the tubal distortion and pelvic inflammation caused by the disease.
Right, so therapeutic management logically has to aim at suppressing that hormonal cycle that feeds these implants.
Exactly. The main medical approach is hormonal suppression, essentially trying to put the disease process on hold or induce remission.
What are the strategies?
Well, strategy one is often using standard combination birth control pills, patches, or rings continuously to suppress ovulation and limit the buildup and bleeding of the implants, making periods lighter and less painful.
Okay, makes sense.
Strategy two involves more powerful drugs called gonadotropin-releasing hormone agonists, or GnRH medications. These essentially shut down the pituitary gland's signals to the ovaries.
So stopping the whole cycle.
Pretty much. They stop the production of the hormones that drive the menstrual cycle entirely. This induces a temporary reversible state similar to menopause. It starves the endometriosis implants.
Or are there others?
Strategy 3 uses a medication called danazol. It's a synthetic androgen, a type of male hormone,
Yeah.
that also suppresses ovarian hormone production and stops the cycle. And NSAIDs are, of course, used for managing the pain itself.
Is surgery involved?
Often, yes. Laparoscopy, minimally invasive surgery, is frequently needed both for definitive diagnosis, seeing the implants, and for treatment. Surgeons can remove the visible implants and cut away the adhesions. This is particularly important if the patient is trying to conceive.
Okay. Before we get to abnormal uterine bleeding, let's quickly tackle premenstrual syndrome, or PMS. Its etiology seems notoriously complex, linked to lots of hormonal and maybe even neurochemical shifts during the second half of the cycle.
Yeah, PMS is tricky. It refers to this distinct cluster of physical and behavioral symptoms that reliably pop up during the luteal phase. That's the 7 to 10 days before menstruation starts. And then, crucially, they disappear once the flow begins.
So it's the timing that defines it.
Absolutely. The leading theory involves altered ratios of estrogen and progesterone during that phase, but it's likely more complex than just that. Rising levels of prolactin might play a role, and importantly, rising levels of aldosterone.
Aldosterone. That's the hormone involved in salt and water balance, right? So that rising aldosterone seems like the key pathophysiology driver for many of the physical PMS symptoms.
Yes, absolutely. Increased aldosterone leads directly to the body retaining more sodium, and water follows sodium. So you get edema, fluid retention.
Ah, so that's the mechanism behind classic physical PMS complaints like bloating, maybe some weight gain, breast tenderness, or swelling.
That's thought to be the primary driver for those symptoms. But simultaneously, there seem to be neurochemical changes happening too.
Like in the brain?
Yeah, there might be a temporary decrease in an enzyme called monoamine oxidase, which could be linked to some of the depressive symptoms people feel, and perhaps decreased activity of serotonin, a key neurotransmitter for mood regulation.
Which could explain the mood swings.
Exactly. That decreased serotonin might contribute to the hallmark mood swings, irritability, anger, tension, and anxiety that many women experience with PMS.
So the multi-system presentation needs careful tracking. We're seeing physical symptoms you mentioned, bloating, breast tenderness, maybe fatigue, headache, weight gain, but also these really distinct behavioral symptoms, anger, tension, trouble concentrating, anxiety, maybe wanting to withdraw socially, poor sleep.
It can be a real mix, and the severity varies hugely between individuals and even cycle to cycle.
So for nursing care and self-management, what's the approach? It sounds like non-pharmacological strategies are really the first step.
They are. The initial focus is almost entirely on lifestyle adjustments and tracking. We strongly encourage clients to keep a detailed menstrual diary or symptom log for at least 1 to 4 months.
Boy.
To confirm that the symptoms truly follow that cyclic pattern, appearing only in the luteal phase and resolving with menstruation. That helps differentiate PMS from other mood disorders.
Okay. And lifestyle.
Dietary changes are central, especially for managing that fluid retention and maybe stabilizing mood. This means a pretty rigorous sodium restriction to counteract the aldosterone effect.
Cut back on salt.
Definitely. Also, focusing on a diet high in complex carbohydrates, things like whole grains, vegetables, legumes, can help stabilize blood sugar and potentially mood. While strictly limiting simple sugar as alcohol and caffeine is important, as those can often exacerbate mood swings and irritability.
Any specific nutrients?
There's some evidence suggesting that ensuring adequate intake of calcium, magnesium, and vitamin B6 might be beneficial. They play roles in muscle function, nerve transmission, and neurotransmitter synthesis.
Okay. And if these lifestyle changes aren't enough for severe cases, what are the medication options?
For severe PMS, particularly if mood symptoms are predominant, oral contraceptives can be very effective by leveling out those hormonal fluctuations throughout the cycle.
Okay.
For severe bloating and fluid retention that doesn't respond to diet, diuretics might be used, but usually just short-term, right before the period.
And for the really tough mood symptoms?
For women suffering primarily from the behavioral side, significant anxiety, depression, or irritability impacting their life. Selective serotonin reuptake inhibitors, SSRIs, can be highly effective.
Antidepressants?
Yes, but often used differently for PMS. They can sometimes be taken either continuously throughout the month or cyclically, starting only during the luteal phase when symptoms appear.
Interesting. Okay, finally in this section, let's address abnormal uterine bleeding, or AUB. The definition and classification seems to cover basically any uterine bleeding that's outside the norm, right? Abnormal amount, duration, or timing, but usually painless.
That's the general idea. AUB is an umbrella term. We use more precise terminology to classify the specific pattern.
Like?
Well, amenorrhea means the complete absence of menstruation. It's primary amenorrhea if a girl hasn't started her period by age 16, or secondary amenorrhea if a woman who previously menstruated stops having periods for 3 or more consecutive cycles.
Okay,
Then there's oligomenorrhea, which refers to infrequent or very scant menstrual bleeding.
got it. But you mentioned some types are more clinically significant.
Yes. The ones that often raise more concern initially are menorrhagia, that's excessively heavy or prolonged menstrual bleeding occurring at regular intervals, and metrorrhagia, which is bleeding, sometimes light spotting, sometimes heavier, that occurs between regular menstrual periods.
Why is the significance of menorrhagia and metrorrhagia considered so crucial, especially in terms of needing prompt evaluation?
Because these patterns, particularly if they are new or persistent, can sometimes be the first sign of underlying pathology within the uterus that might increase the risk of uterine cancer.
Ah, so it's a cancer warning sign?
It can be. Menorrhagia and metrorrhagia require timely evaluation to rule out things like benign endometrial polyps or a condition called endometrial hyperplasia.
What's that?
Hyperplasia is an excessive abnormal thickening of the uterine lining, often caused by prolonged exposure to estrogen without enough progesterone to balance it out. Some types of hyperplasia are precancerous. And of course, these bleeding patterns could potentially signal frank uterine cancer itself. This is especially true for any bleeding that occurs after menopause. Postmenopausal bleeding is basically considered cancer until proven otherwise and absolutely requires immediate investigation.
Okay, really critical point there. So what are the primary management options for AUB, assuming cancer is ruled out or depending on the cause?
Well, treatment really depends heavily on the underlying cause, the severity, and the patient's reproductive goals. Options can range from hormone therapy, maybe using progesterone, or combined contraceptives to regulate the cycle and control bleeding,
Right.
to surgical interventions. A common procedure is dilation and curettage, or D&C.
What does that involve?
The cervix is dilated, and the lining of the uterus is gently scraped or suctioned out. This can help control acute heavy bleeding, and importantly, it provides tissue samples for biopsy to diagnose the cause.
Okay. What if the bleeding is chronic and doesn't respond? For patients who have completed their childbearing and are suffering from persistent heavy bleeding, endometrial ablation is an option. Ablation.
Yes. This procedure uses methods like laser, heat, or freezing to destroy the endometrial lining. The goal is to permanently stop or significantly reduce menstrual flow. It also ends reproductive capacity.
So it's definitive.
It's less invasive than a hysterectomy,
Yeah.
but definitive in ending menstruation and fertility. Hysterectomy, the surgical removal of the uterus, is generally reserved for cases where other treatments fail, if there's malignancy or if there are very large fibroids causing severe symptoms.
All right, let's shift focus now. We're moving into a set of conditions that really highlight what happens when the body's internal support system starts to weaken or fail. We're talking about uterine prolapse, cystocele, and rectocele. Our expert mentioned they often share a common etiology.
They absolutely do. At their core, all three conditions represent a failure of structural integrity. The unified cause is significantly weakened pelvic floor musculature, those muscles forming a sling at the base of the pelvis, and a weakening of the supporting ligaments that normally hold the pelvic organs in place.
And what causes that weakening?
Overwhelmingly, the primary cause is the immense mechanical stress placed on these structures during pregnancy and childbirth,
Makes sense.
particularly things like very rapid deliveries, delivering large babies, experiencing unrepaired tears or lacerations of the perineum or vagina during birth, and having multiple pregnancies over time. Each event can stretch and potentially damage those supports.
Is aging involved too?
Yes. Then, over time, you add in the natural loss of muscle tone and elasticity that comes with aging, and particularly the decrease in estrogen levels after menopause, which also affects tissue integrity. Eventually, these supportive structures can just give way.
Okay, let's focus first on uterine prolapse. This is when the uterus itself drops down into the vaginal canal. Our sources classify the severity by degree.
Correct. We grade uterine prolapse based on how far the uterus descends. First-degree prolapse means the cervix has dropped into the lower part of the vagina but not reached the opening.
Okay.
Second degree is when the cervix, or the entire uterus, descends right down to the vaginal opening.
Visible at the entrance.
Potentially, yes. And third-degree prolapse, which is often called proscedentia, is the most severe form. This is when the entire uterus prolapses completely outside the vaginal opening. It essentially turns the vaginal canal inside out as it comes down.
Wow. Does prolapse usually happen alone?
Rarely. Uterine prolapse is typically accompanied by some degree of cystocele or rectocele because the same weakened supports affect all the pelvic organs.
So what is the patient actually reporting during the clinical presentation? What does it feel like to them?
The classic description from the client is a feeling of a lump or pressure or a sense of heaviness bulging or protruding from the vagina.
Something coming down.
Exactly. And this sensation is almost always worse when they're standing up for long periods or straining, like having a bowel movement, or often just by the end of the day, simply due to gravity pulling everything down.
Any other symptoms?
They commonly report a persistent dull ache in the lower back. And because, as we said, it's often accompanied by cystocele or rectocele, they frequently describe difficulty either with completely emptying their bladder or difficulty passing stool.
Okay, so for management, especially in nursing care, conservative methods seem to be the first approach.
Yes, absolutely.
Mm-hmm.
For mild to moderate prolapse, we start with extensive patient education on Kegel exercises.
A pelvic floor squeezes.
Exactly. Teaching them how to correctly identify and repeatedly contract and relax those pelvic floor muscles. The goal is to rebuild muscle strength and provide better natural support.
Does that really work?
It can significantly improve symptoms for many women with milder prolapse and help prevent worsening. Another non-surgical option is a pessary.
What's that?
A pessary is a removable device, usually made of medical-grade silicone or plastic, that's inserted into the vagina. It comes in various shapes and sizes, like a ring or a cube, and it works by physically propping up the uterus and vaginal walls.
So it provides support from the inside.
Precisely. Nursing education regarding pessaries is critical, though. The patient needs to learn how to properly insert, remove, and clean the pessary regularly to prevent complications like chronic vaginal irritation, ulceration, or infection.
And when conservative methods aren't enough?
Surgery becomes the option. Specifically for severe third-degree prolapse, procedentia, or symptomatic prolapse unresponsive to conservative measures, a hysterectomy removal of the uterus might be performed to remove the structure that's actually prolapsing, often combined with repairs of the vaginal supports.
Okay, now let's quickly detail those two common companions, cystocele and rectocele. A cystocele involves the bladder herniating.
That's right. A cystocele is the herniation or bulging of the bladder downward into the anterior front wall of the vagina. It happens because the supportive wall between the bladder and vagina has weakened.
And the key functional symptom there, what problem does it cause?
The hallmark symptom is stress incontinence.
Leaking urine.
Yes, the involuntary leakage of urine, specifically when intra-abdominal pressure increases when coughing, sneezing, laughing, lifting something heavy, or exercising.
Why does that happen?
Because the prolapse displaces the bladder neck and urethra, compromising the closure mechanism. Also, because the bladder isn't in its normal position and might not empty completely, clients with cystoceles are often at high risk for urinary stasis retained urine, which can lead to recurrent urinary tract infections, UTIs.
Okay. And the rectocele, that involves the rectum herniating.
Correct. A rectocele is the herniation or bulging of the rectum into the posterior back wall of the vagina due to weakness in the rectovaginal septum.
And the defining symptom here.
The most characteristic functional symptom is difficulty with bowel evacuation. Clients often report chronic constipation and may develop hemorrhoids due to straining. But critically, many clients find they have to manually assist defecation by using what's called digital pressure or splinting. They actually have to press on the bulge of the rectocele from inside the vagina to reposition the rectal pouch enough to allow stool to pass.
Wow, that must be very difficult and, well, embarrassing for patients.
It's a very sensitive symptom, and often patients are reluctant to mention it unless specifically asked.
So the surgical management for these is called a colporrhaphy.
That's the term, yes. For a cystocele repair, it's an anterior colporrhaphy, or anterior repair. For a rectocele repair, it's a posterior colporrhaphy, or posterior repair.
And what do these surgeries actually do?
Essentially, these procedures involve surgically tightening and reinforcing the weakened supportive tissues, the fascia between the vagina and the bladder, for anterior repair, or between the vagina and the rectum for posterior repair. They effectively shorten and strengthen those pelvic muscles and fascia to create a better hammock or support for the bladder or rectum.
Okay. And you mentioned there's a crucial piece of patient education related to the outcome of these repairs, something nurses really need to convey.
Yes, because the explicit goal of these colporrhaphy procedures is to tighten and shorten the stretched out vaginal walls and underlying supports.
Right.
A potential consequence is that the surgery may result in shortening the overall functional length or caliber of the vagina itself.
Oh, and that could cause issues.
It could. Patients absolutely need to be counseled preoperatively that this physical change, while fixing the prolapse or bulge, might potentially lead to new discomfort or pain during sexual intercourse dyspareunia, even if their prolapse symptoms are completely relieved. It's a really important expectation to set.
Okay, we're shifting gears a bit now, moving into menopause, which is, of course, a natural life cycle transition, but it's one that dramatically changes the body's internal environment and that presents new risks and new challenges. How is menopause officially defined?
Menopause is officially confirmed after a woman has experienced 12 consecutive months without a menstrual period. This signals the natural cessation of ovarian function. The ovaries stop releasing eggs and significantly decrease their production of estrogen and progesterone.
And the timing.
It typically occurs somewhere between the ages of 40 and 55, with the average age being around 51 or 52 in many Western countries. However, factors like undergoing certain medical treatments, having specific chronic illnesses, or smoking can sometimes accelerate this process, leading to an earlier onset.
Okay, and the clinical symptoms. They seem to present across a timeline. How do we differentiate the earlier symptoms versus the later manifestations of menopause?
That's a good way to think about it. The early onset symptoms are largely driven by the fluctuating and then rapidly declining estrogen levels around the time of the final menstrual period, perimenopause, and immediately after.
These are the classic ones.
Yes, this includes vasomotor symptoms, hot flashes, night sweats, which can significantly disrupt sleep. Also, minor mood shifts, irritability, maybe some difficulty concentrating, and urogenital symptoms due to vaginal atrophy, the thinning, drying, and loss of elasticity of the vaginal tissues, which can cause dryness, itching, and painful intercourse.
Okay, those are the early ones. What about later?
The late onset symptoms are more structural and systemic consequences that develop over the years following menopause, primarily due to the long-term absence of estrogen's protective effects. The most significant of these is an increased risk and progression of osteoporosis, low bone density leading to fragile bones, and increased fracture risk.
Ah, because estrogen helps maintain bone strength.
Exactly. Bone density starts to decline much more rapidly after menopause without estrogen's influence. There's also an increased risk of cardiovascular disease as estrogen has some protective effects on heart health.
Got it. Now, our sources provide some really detailed, practical nursing education points for managing these changes, focusing on comfort and self-care, which seems crucial.
Absolutely. Providing practical, actionable advice is essential for helping women navigate this transition comfortably. For managing hot flashes, simple things can make a big difference.
Hi.
Dressing in layers so clothing can be easily removed, keeping cool water handy to sip on or splash on the face, using fans, and, importantly, working with the client to identify and then try to minimize their individual triggers.
Triggers for hot flashes.
Yeah, common ones include consuming spicy foods, caffeine, or alcohol. Stress can also be a trigger for some.
Okay. And for managing the vaginal discomfort, the atrophy.
We recommend using water-based or silicone-based vaginal lubricants during intercourse to reduce friction and pain. Vaginal moisturizers used regularly can also help restore moisture. And, crucially, we emphasize the benefit of remaining sexually active if comfortable.
Why is that important?
Because sexual activity helps maintain blood flow to the vaginal tissues, which can help preserve elasticity and function. We also reinforce the importance of continuing Kegel exercises
Cables again. Why here?
to help strengthen the pelvic floor muscles, which can sometimes weaken further with low estrogen, potentially worsening urinary incontinence issues that might arise or worsen around menopause. And then there's comprehensive lifestyle advice.
What does that broader lifestyle advice look like during and after menopause?
It's really about long-term health protection. Regular weight-bearing exercise like walking, dancing, lifting weights becomes absolutely non-negotiable. It's vital for combating osteoporosis risk and also benefits cardiovascular health.
Okay.
We advise ensuring a balanced diet rich in calcium and vitamin D for bone health, and strongly recommend stopping smoking, as smoking is known to accelerate bone loss and is also linked to early onset of menopause. We also often teach relaxation techniques like deep breathing or mindfulness to help manage stress and the emotional volatility that can sometimes accompany the hormonal shifts.
And we have to reiterate a critical point we touched on earlier, right? Regarding bleeding. A critical assessment finding.
Yes, absolutely critical. Any vaginal bleeding that occurs after menopause has been firmly established, i.e. after 12 months without a period, is considered abnormal and potentially serious. It must be investigated promptly by a healthcare provider to rule out underlying pathology, particularly endometrial cancer. Never assume postmenopausal bleeding is normal.
Got it. Okay, let's move into our oncological concerns now, starting with cervical cancer. Our sources note it's often diagnosed in clients between 30 and 50, and squamous cell carcinoma is the most common type. Early diagnosis is key here, isn't it? Because it's highly curable if caught early.
Extremely key. The prognosis is dramatically better with early detection.
So what's the subtle but really critical early presentation we need to be aware of?
The very early symptoms are often quite subtle and easily missed or dismissed. It might just be a thin, watery vaginal discharge, maybe slightly blood-tinged.
Yep.
However, the most specific early symptom that should absolutely trigger immediate alarm bells is painless bleeding between periods, or particularly postcoital bleeding that occurs immediately after sexual intercourse.
Why after intercourse specifically?
Because the abnormal cancerous tissue on the cervix is often very fragile and vascular. The minor trauma of intercourse can cause it to bleed easily. That's a classic sign that needs urgent evaluation.
And late symptoms.
Late symptoms unfortunately indicate that the cancer is likely spread beyond the cervix, maybe invaded nearby tissues or metastasized. These can include referred pain, often to the back, hips, or down the legs, blood in the urine, hematuria, or bloody stools if it invades the bladder or rectum, and systemic signs like unexplained weight loss and fatigue.
So our primary defense against reaching those late stages is screening.
Absolutely. Regular screening with the cervical pap test or pap smear is critical.
How does that help?
The pap test allows us to detect precancer cellular changes, called dysplasia or cervical intraepithelial neoplasia, CIN, on the cervix before they actually develop into invasive cancer. We can often treat these precancerous changes relatively easily and prevent cancer from ever forming. HPV testing is also now commonly done alongside or even replacing pap tests in some guidelines, as persistent infection with high-risk HPV types is the main cause of cervical cancer.
And if the screening test is abnormal,
Then further investigation is needed. Usually a colposcopy exam, where the cervix is examined under magnification, often with application of solutions that highlight abnormal areas. Biopsies are then taken from any suspicious areas to get a definitive tissue diagnosis and determine the stage of any abnormality or cancer found. This guides the treatment plan.
okay. Now, for cases that are more advanced and require treatments like hysterectomy or radiation therapy, what are the major nursing management concerns post-treatment?
After major surgery like hysterectomy, or especially during and after pelvic radiation therapy, nursing priorities include effective pain control, of course, but also meticulously maintaining skin and tissue integrity.
Because radiation can be damaging.
Radiation therapy to the pelvis can be highly damaging to the surrounding healthy tissues, the bladder, rectum, vagina, and skin. So meticulous skin care, managing diarrhea or bladder irritation, and patient education on self-care are vital.
Any major long-term complications to watch for?
Yes. A significant potential long-term complication, particularly after extensive surgery or radiation for cervical cancer, is fistula formation.
A fistula? What's that?
It's an abnormal tunnel or connection that forms between two organs that shouldn't be connected. In this context, it's most commonly between the vagina and the bladder, a vesicovaginal fistula, or between the vagina and the rectum, a rectovaginal fistula.
And that causes leakage.
Yes. A vesicovaginal fistula causes constant leakage of urine into the vagina. A rectovaginal fistula causes leakage of gas or stool into the vagina. These are devastating complications that significantly impact quality of life and usually require complex surgical repair. So monitoring for any signs of this is an important long-term nursing consideration.
Okay. Let's move to ovarian cancer. We noted earlier this is often called the most lethal gynecological cancer, and you highlighted the profound diagnostic challenge. Why is it so hard to diagnose?
It remains so lethal precisely because, unfortunately, we still lack a reliable, effective, and widely accepted screening test for the general population. There's no equivalent to the pap test for cervical cancer or mammography for breast cancer.
So how is it usually found?
Diagnosis is typically made very late in the disease process. Often it's discovered incidentally during pelvic surgery for another reason, or when symptoms finally become severe enough to prompt investigation, which usually means the disease is already quite advanced, frequently having spread throughout the abdominal cavity, stage 3 or 4.
Which makes treatment much harder and outcomes poorer.
Exactly. This delay in diagnosis is the primary reason for its high mortality rate compared to other gynecologic cancers. That's why recognizing potential symptoms, even vague ones, becomes absolutely critical.
Okay, so if screening isn't reliable, what are those early, often vague symptoms to watch for? The ones that, if persistent, should really prompt a clinical workup.
These symptoms are notoriously subtle and nonspecific. They often mimic common gastrointestinal complaints or are easily dismissed as just part of aging.
Like what specifically?
Things like persistent, vague abdominal discomfort or pain, indigestion or dyspepsia that doesn't go away, feeling bloated frequently, a feeling of pelvic pressure or heaviness,
Okay.
and crucially, early satiety, feeling full very quickly after eating only a small amount of food. Also, maybe noticing an increase in abdominal size or girth, even without significant weight gain, potentially due to fluid buildup, tights, or the tumor itself.
And the key is persistence.
Yes. Any of these symptoms, especially if they are new, occur almost daily and persist for several weeks, should absolutely not be ignored. They warrant an aggressive investigation, usually starting with a thorough pelvic exam and imaging like a transvaginal ultrasound. During the pelvic exam, a clinician might feel a palpable pelvic mass, often described as fixed, firm, and irregular, which is highly suspicious.
We mentioned the CA-125 blood test earlier in relation to PID. Can't that be used for ovarian cancer screening or diagnosis?
The CA-125 antigen level is a tumor marker that can be elevated in many women with ovarian cancer, especially epithelial ovarian cancer.
Right.
However, it is not specific enough or sensitive enough to be used as a standalone screening tool for the general population.
Why not?
Because CA-125 levels can also be elevated by many benign conditions like endometriosis, PID, fibroids, liver disease, or even just during menstruation in some women. It also misses a significant number of early-stage ovarian cancers.
So it has limitations.
Major limitations for screening. It's sometimes used to help evaluate a pelvic mass if cancer is suspected, or more commonly, to monitor a patient's response to treatment or check for recurrence after a diagnosis has already been made. But definitive diagnosis still requires surgery and tissue biopsy.
Understood. Okay, finally in this section, let's turn to breast cancer. The basic etiology involves uncontrolled growth of breast cells, but our sources highlight a clear set of risk factors, particularly related to lifetime estrogen exposure. Can you elaborate?
Yes, a central theme in breast cancer risk seems to be prolonged exposure of breast tissue to estrogen over a woman's lifetime. Factors that increase this cumulative exposure duration are associated with higher risk.
Such as?
Things like starting menstruation at an early age, early menarche, experiencing menopause at a later age, late menopause, having a first full-term pregnancy late in life, typically considered after age 30, or never having given birth, and using prolonged combined hormone replacement therapy, HRT, after menopause, although risks vary with type and duration.
So longer reproductive window, more exposure.
Essentially, yes. Other major known risk factors include genetic predisposition, having a strong family history of breast or ovarian cancer, or carrying specific gene mutations like BRCA1 or BRCA2.
Lifestyle factors, too.
Yes, lifestyle factors also play a significant role. These include things like maintaining a diet high in saturated fat, obesity, especially after menopause, as fat tissue produces estrogen, lack of regular physical exercise, and regular alcohol consumption. Smoking is also increasingly recognized as a risk factor.
Okay. So what are the most suspicious findings during assessment? What should raise alarm bells during a clinical breast exam or self-exam?
The most common initial finding that leads to diagnosis is a lump or mass in the breast. While many lumps are benign, the characteristics most suspicious for malignancy are lumps that feel non-tender, usually not painful, fixed, meaning they don't move freely under the skin, they feel attached, hard, like a rock or pebble, and have irregular or poorly defined borders.
Where are these usually found?
They are most commonly found in the upper outer quadrant of the breast, near the armpit, because that's where most breast tissue is located. But they could occur anywhere.
Any other warning signs besides the lump?
Yes. Other potential warning signs include visible changes to the breast skin, like dimpling or puckering, sometimes described as looking like an orange peel, peau d'orange. Asymmetry, where one breast changes size or shape compared to the other. Retraction or indentation of the nipple, or any spontaneous discharge from the nipple, especially if it's bloody or clear.
Got it. Now, following treatment, which often involves surgery like a mastectomy, frequently with removal of axillary lymph nodes, the priority nursing management focus shifts immediately. What's the major complication we need to prevent?
The number one priority post-mastectomy, especially if axillary lymph nodes were dissected or removed, is the prevention and management of lymphedema.
Lymphedema, swelling.
Yes, it's chronic swelling of the arm on the affected side. It happens because removing lymph nodes disrupts the normal drainage pathway for lymphatic fluid from the arm. The fluid can back up, causing swelling, heaviness, discomfort, and increasing the risk of infection in that limb. It can become a lifelong issue.
So, what's the absolute nursing rule to prevent this?
The cardinal rule drilled into every nurse is no blood pressure readings, and no venipuncture, blood draws, and no VOR-V lines placed on the affected arm of a mastectomy patient, ever if possible.
Never on that side.
Never. Any constriction or puncture wound on that arm can potentially trigger or worsen lymphedema. The arm should also be positioned elevated on pillows, especially in the immediate postoperative period, to use gravity to help facilitate fluid drainage.
What else is important in post-mastectomy care?
Encouraging early, gentle range of motion exercises for the affected arm and shoulder is important to prevent stiffness and frozen shoulder, adhesive capsulitis, and extensive patient education is vital.
Education about what?
Educating the client on lifelong lymphedema, precautions, things like meticulous skin care on that arm, avoiding any cuts, burns, or injuries, avoiding tight clothing or jewelry, using insect repellent, and seeking prompt medical attention for any signs of infection, redness, warmth, increased swelling in that limb. If the client is discharged home with surgical drains still in place, like a Jackson Pratt or Hemovac drain, we also provide detailed instructions on how to manage and empty the drain and measure the output.
Okay, we're concluding our deep dive today with infertility. This is obviously a diagnosis that can be incredibly emotionally challenging and stressful for many couples. What is the clinical definition that we use for infertility?
Infertility is generally defined as the inability to achieve conception after 1 full year of regular, unprotected intercourse.
1 year of trying.
Yes, that's the standard time frame used for investigation for couples where the female partner is under 35. For women 35 or older, evaluation might be considered after just 6 months of trying due to the age-related decline in fertility.
Is there another part to the definition?
Yes. The definition also includes the inability to carry a pregnancy to term and deliver a live fetus after having achieved 3 or more consecutive spontaneous conceptions. This is often referred to as recurrent pregnancy loss, which is also investigated under the umbrella of infertility.
Okay. When investigating infertility, the diagnostic approach requires looking at both partners, right? An etiology split, because the cause isn't always just on one side.
Absolutely. It's crucial to evaluate both partners concurrently, as the cause can be attributed solely to the female partner about a third of the time, solely to the male partner about a third of the time, and related to factors in both partners or be unexplained in the remaining third.
So looking at potential female causes first, our sources list quite a few possibilities.
Yes, the potential female factors are vast. They can broadly be categorized into hormonal dysfunction, maybe problems with ovulation, like polycystic ovary syndrome, PCOS, insufficient gonadotropin secretions from the pituitary, or issues with the luteal phase of the cycle needed to support early pregnancy.
Okay, what else?
Structural abnormalities are a major category. This includes damage or blockage of the fallopian tubes, often from scarring caused by previous PID, like we discussed.
Ah, the PID connection again.
Exactly. Or structural issues with the uterus itself, like congenital abnormalities, example, a uterine septum, large fibroids distorting the cavity, or adhesions inside the uterus, Asherman syndrome. Ovarian factors like diminished ovarian reserve, low egg count quality are also key.
Any others?
Psychological factors and significant stress can sometimes impact ovulation and fertility, and rarely there can be immunological issues, like the woman's body producing antibodies against her partner's sperm. And we absolutely have to revisit endometriosis here.
Right, because the scarring and inflammation from endometriosis is a very common cause of secondary infertility.
A very common cause, yes. It can distort anatomy, impair tubal function, and create an inflammatory environment hostile to conception.
Okay. Now, shifting to the male partner, what are the primary areas of investigation for male factor infertility?
For the male partner, the investigation primarily focuses on potential problems with sperm production, transport, or function. This includes semen disorders, issues with the quantity, volume, motility, how well the sperm swim, or density, the total number or concentration of sperm in the ejaculate. Morphology, the shape of the sperm, is also assessed.
What can cause those semen issues?
Various things, maybe hormonal imbalances affecting sperm production. Systemic disorders like uncontrolled diabetes mellitus can impact erectile function and sperm quality. History of certain infections, like mumps that led to orchitis, testicular inflammation, can damage sperm production. Varicocele, enlarged veins in the scrotum, are a common finding. Or structural defects affecting the tests themselves or the ducts that transport sperm. Lifestyle factors like smoking, excessive alcohol use, drug use, and obesity can also negatively impact sperm parameters.
Got it. So this clear split in potential causes dictates the diagnostic contrast. What are the key initial tests typically done for each partner?
For the female client, the initial workup often involves tracking her cycles to confirm ovulation. A simple way is using a basal body temperature, BBT chart.
Tracking daily temperature.
Yes, a slight rise in basal body temperature occurs just after ovulation due to progesterone production. So charting this daily can help confirm if and when ovulation is happening. We also often check hormone levels, particularly serum progesterone levels in the mid-luteal phase, to confirm ovulation quality. And structural integrity tests might be done.
Like checking the cubes.
Exactly. A common test is a hysterosalpingogram, HSG, an X-ray procedure using contrast dye to visualize the uterine cavity and check if the fallopian tubes are open. Ultrasound is also used extensively to assess the ovaries and uterus. Sometimes an endometrial biopsy is done to assess the uterine lining.
Okay. And for the male partner, what's the cornerstone test?
For the male partner, the single most conclusive and fundamental test is the semen analysis.
That's the main one.
It's the cornerstone of the male fertility evaluation. It provides a comprehensive assessment of sperm count, concentration, motility, percentage of moving sperm and how well they move, volume of ejaculate, and morphology, percentage of normally shaped sperm. This test alone often points towards or away from a significant male factor.
Okay. So finally, let's talk about the core of nursing and emotional support. When a couple is navigating this incredibly stressful, often lengthy, and uncertain process of infertility diagnosis and treatment, what is the nurse's role?
The nursing role is absolutely multifaceted and crucial. It's partly educational, partly supportive, partly coordinating. We assist the couple in optimizing their general health, providing guidance on achieving a healthy weight, nutritional advice, strongly encouraging smoking cessation, and limiting alcohol for both partners.
Okay.
We absolutely must teach and encourage stress reduction techniques. The entire process of infertility investigation and treatment can be incredibly stressful, emotionally draining, and often involves a cycle of hope and disappointment. Helping the couple manage this stress is paramount.
And the emotional side.
Providing consistent emotional support is perhaps one of the most vital roles. Being a trusted source of accurate information about the complex diagnostic tests and various treatment options, like ovulation induction, IUI, IVF. Being an empathetic listener, validating their feelings of frustration, grief, or anxiety.
Being that constant resource.
Exactly. We can also facilitate connections to patient support groups, which can be incredibly helpful for couples to connect with others going through similar experiences. And importantly, if treatments are unsuccessful, or if the couple chooses not to pursue certain options, our role includes helping them explore and process alternatives, such as using donor gametes, sperm or eggs, surrogacy or adoption if building a family remains their goal. Hashtag tag outro.
Wow, this deep dive has truly been comprehensive. It's really demonstrated the sheer complexity, but also the interconnectedness of female reproductive health. We've journeyed from understanding how something like a pelvic infection, PID, can physically alter the pelvic architecture and lead to lifelong challenges like chronic pain and infertility, all the way to recognizing just how vital the integrity of that pelvic floor support system is, preventing structural collapse like prolapse later in life.
It really highlights that interconnectedness. And if we try to connect all this to the bigger picture, I think maybe the most profound clinical realization that emerges from reviewing all this is the absolute critical necessity of responding promptly to those vague or persistent symptoms we discussed.
Especially for the cancers.
Especially for the cancers.
Yeah.
Because reliable screening is still lacking for something as lethal as ovarian cancer. And because we know early detection radically changes the prognosis for cervical and uterine cancers. We really empower ourselves, and we empower our clients by never dismissing persistent pelvic pressure, chronic bloating that doesn't resolve, unusual discharge, or any postmenopausal bleeding. Early investigation, early intervention, it truly is everything in those scenarios.
That's a powerful takeaway. And I think that leads perfectly into our final provocative thought for you, our listener, to consider. The very systems we've explored today, the hormonal system, the structural supports, the inflammatory responses, and the oncological risks, they aren't operating as independent islands within the body.
Not at all.
The balance of hormones profoundly impacts bone density decades later in menopause, just as it drives fluid retention month to month in PMS. The physical integrity of the pelvic floor, often impacted by childbirth, dictates functional outcomes related to bladder, bowel, and uterine support throughout aging. It underscores that the most effective clinical understanding, and therefore the best care, really requires viewing the female body not as a collection of separate potential issues, but as one incredibly intricate, deeply interconnected system.